So let's get started. Good evening, everyone. Welcome, and thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Tanya Behel, and I'm a project manager for the Cancer Institute. There are a few housekeeping items that we want to review before we start. If you join via Zoom, during the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants on Zoom are not able to speak during the conference, but again, we encourage feedback via the chat option. Tonight, we are excited to welcome Dr. David Bartlett, Dr. Suzanne Coopey, and Dr. John Nakayama, who will be speaking about what can you do to prevent or slow down cancer, truths and myths. Dr. Suzanne Coopey serves as Director of Breast Surgery for Allegheny Health Network and Chair of the Breast Cancer Program for AHN Cancer Institute. She is also an Associate Professor of Surgery for Drexel University College of Medicine. Dr. Coopey completed general surgery training at Cleveland Clinic, then went on to complete a breast surgical oncology fellowship at the combined Mass General Hospital, Brigham and Women's Hospital, Dana-Farber Cancer Institute program in 2011. Upon completion of training, she joined the Division of Surgical Oncology at Mass General Hospital with a faculty appointment at Harvard Medical School. She joined Allegheny Health Network in 2021. Dr. John Nakayama is a gynecologic oncologist who specializes in treating women who have ovarian, cervical, uterine, endometrial, and vulvar cancers. He has expertise in performing minimally invasive and robot-assisted surgeries, and his research activities include inherited gynecologic cancers. He is also an associate professor of OBGYN for Drexel University College of Medicine. After earning his medical degree from John A. Burns School of Medicine in Honolulu, Hawaii, Dr. Nakayama completed an obstetrics and gynecologic residency at Duke University Medical Center in Durham, North Carolina. He then completed a gynecologic oncology fellowship at the University of Virginia in Charlottesville. Dr. Nakayama holds several positions with NRG Oncology, a National Cancer Institute National Clinical Trials Network, including with the NRG Ovarian Cancer Core Committee and the NRG Ancillary Data Committee. He is also on the SGO Clinical Practice Committee and was the co-editor of the SGO Anti-Neoplastic Therapy Handbook. Dr. David L. Bartlett is chair of the AHN Cancer Institute. An internationally recognized cancer surgeon, he is a pioneer in abdominal cancer treatment and a dedicated prolific researcher. He is also past president of the Society of Surgical Oncology. He served as a senior investigator in the surgery division of the Center for Cancer Research at the National Cancer Institute, where he developed innovative surgical techniques to treat patients with abdominal and liver cancers and performed cutting-edge laboratory research in viral-based immune therapies. Dr. Bartlett received his medical degree from the University of Texas Medical School at Houston and completed his surgical residency at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. He continued his training with a fellowship in surgical oncology at Memorial Sloan Kettering Cancer Center in New York City. He completed research fellowships at MD Anderson Hospital and in Houston, Texas, and the Hospital of the University of Pennsylvania. Board certified by the American Board of Surgeons, Dr. Bartlett holds membership in several professional surgical and oncology societies. He received many academic honors during his career and has been chosen as one of Pittsburgh's best doctors every year since 2006. He has published over 380 research papers in medical journals and has contributed chapters to more than 40 publications. In addition, he lectures widely at national and international meetings and conferences. Welcome, Dr. Bartlett, Dr. Coopey, and Dr. Nakayama.
Hi guys, thanks for coming in person and virtually. I am specifically going to be talking today about the risks associated with breast cancer. So I see patients all the time, and the biggest question I think I get is, why did I get breast cancer? It doesn't run in my family. What caused this? What did I do wrong? And we know that only 15 to 20% of breast cancers are familial, and about 5 to 10% are due to genetic mutations. We estimate that about 50% are due to hormonal or reproductive factors, mammographic breast density, and proliferative breast disease. That leaves 30% that are estimated to be attributed to lifestyle and environmental factors. These are what we consider the modifiable risk factors, and this is what I'm going to talk about today. Specifically, we're going to focus on diet, alcohol, exercise, smoking, and hormone replacement therapy. With regard to breast cancer risk, I found some articles specifically on things like dairy, red and processed meat, sugar-sweetened beverages, soy, and coffee. I'm not going to talk a lot about the health benefits of fruits and vegetables or eating whole grains. I think everyone understands that those are good for you. People have worried about dairy, though, for a long time because they're worried about potential pro-carcinogenic effects of dairy, mostly related to cow's milk and increase in hormone levels, such as estrogen and insulin-like growth factor. Although dairy also has a lot of really good healthy nutrients like vitamin D, calcium, and essential fatty acids. What all the research is pointing to is that dairy is healthy. It does not cause breast cancer. There was a large study called the Nurses' Health Study that included 90,000 premenopausal women. They enrolled women that were ages 27 to 44, and they asked them about their adolescent dairy consumption during their high school years. And then they also asked them about what they called their early adulthood dairy consumption during ages 27 to 44. And I love that they considered that early adulthood. What they found was there was absolutely no association between premenopausal or postmenopausal breast cancer risk with total dairy intake, and also no association if they broke it down into low-fat dairy, high-fat dairy, milk, cheese, ice cream, or yogurt. Similarly, in the Black Women's Health Study, which enrolled 59,000 African-American women ages 21 to 69, they found no statistically significant associations between breast cancer risk, total dairy intake, including whole milk, low-fat milk, hard cheese, yogurt, and ice cream. So dairy is safe. Continue to eat it. On the other hand, red and processed meat seems to be associated with an increased risk of breast cancer. When we're talking about red meat, most of the studies include things like unprocessed beef, veal, pork, lamb, mutton, which is sheep, horse and goat, and processed meat, they consider meat that's been transformed by salting, curing, fermenting, and smoking, like bacon, sausage, salami, hot dogs. And the mechanisms of carcinogenesis are actually quite a few. Higher intake of nitrites and nitrates, hormonal steroids that are given for growth stimulation of beef cattle, and ingestion of heterocyclic amines that occur when you cook the meat at very high temperatures. I know this is probably a little bit hard to see, a little bit small, but this is a review that I found, a systemic review and meta-analysis of 18 studies, which included 2.9 million women. What they did was they compared the highest to the lowest intake of red meat consumption and processed meat, and the relative risk was definitely increased for both for breast cancer risk. I also found this interesting study out of Mexico where apparently they drink a lot of soda. And they found that when they looked at intake of carbonated sugary soft drinks, that there was an increased risk of breast cancer in premenopausal women. And that premenopausal women who drank one or more sugar-sweetened beverages per day had a 1.78 odds of breast cancer compared to those who drank one or fewer. They did not look at diet soda or those with artificially sweetened beverages. And this risk held true even when they adjusted for other factors like age, place of residence, total caloric intake, socioeconomic status, education level, physical activity, BMI, alcohol, tobacco, diabetes, hormone replacement therapy, everything. So a lot of soda intake does not seem to be great. Soy is something that a lot of people ask about because for many decades, people have believed that soy intake could cause breast cancer or increase the risk of breast cancer recurrence because most breast cancer is stimulated by estrogen and soy is considered a phytoestrogen. Well, in fact, so soy is a dietary isoflavone structurally similar to 17-beta-estradiol. What they found is that Asian populations that actually have a very high soy intake in their diet have lower breast cancer risks. The thought is that the isoflavones act as a functional estrogen antagonist. So it binds the estrogen receptor, but it does not produce an effect, and it actually prevents estrogen from binding. So it exerts a protective effect. In this meta-analysis here, kind of in the middle of the slide, Wei and colleagues looked at a group of 630,000 women, and they found that there was no increased risk of breast cancer associated with high soy intake, and overall potentially a very slight benefit. So if you like tofu edamame, it is safe to eat that. This was also a study on soy, a multi-ethnic cohort of 84,000 women from Hawaii and Los Angeles. And they looked at their self-reported intake of soy. And again, they found no significant association between dietary soy and breast cancer risk with 13 years of follow-up. They broke it down into different races and ethnicities, and this held true for Japanese women, white women, Latina, African American, and Native Hawaiian. Good news regarding coffee as well. There's been no link between coffee and breast cancer. In fact, there's some studies now showing that among postmenopausal women who drink more than 1 cup of coffee a day, there may be a slight protective effect. And some limited evidence that's coming out that coffee consumption may be good in terms of improving survival rates. There are proposed anti-carcinogenic mechanisms of coffee being antioxidant and anti-inflammatory. And they're seeing it with regular coffee and decaf coffee, so it's not just a caffeine effect. The bad news is alcohol is not great. Even moderate alcohol intake of more than 1 or 2 drinks per day is associated with a risk of breast cancer. When they talk about standard drinks, they're talking about 1.5 ounces of liquor, 5 ounces of wine, or 12 ounces of beer. The carcinogenesis of alcohol is that the ethanol is oxidized into acetaldehyde and then acetate, and the acetaldehyde is carcinogenic and mutagenic by binding to DNA and proteins. In the study that came out looking at alcohol consumption and site-specific cancer risks, the authors separated alcohol intake into light drinkers, which was 1 or fewer drinks per day, moderate drinkers, which were 4 or less drinks per day, and heavy drinkers that drank 4 or more drinks per day. And they found that light drinkers didn't have much of an increased risk, or really no increased risk of breast cancer. But moderate drinkers started to have an increased risk, and they looked at it in European studies, North American studies, and Asian studies, and all showed an increased risk. And the risk went up with heavy drinking. So we do generally recommend that you limit your alcohol intake to less than 1 drink per day. There's also a significant health benefit in terms of breast cancer risk from exercise. Exercise can actually lower circulating levels of hormones like estrogens and androgens, and this definitely helps reduce the risk of postmenopausal breast cancer. It reduces systemic inflammation. It can prevent weight gain and lower excess adiposity or fat. And adiposity has been linked with inflammation and oxidative stress. This is a meta-analysis that included 38 prospective studies in 4.1 million women. And what they did is they compared the highest level of physical activity to the lowest level of physical activity. And they found that increased physical activity was associated with a reduction of breast cancer risk with a relative risk of 0.88. This held true when they were looking at location. So the US, Europe, Asia, in all locations, exercise improved breast cancer risk. This was true regardless of a patient's BMI. So everyone benefits from alcohol, regardless of what your BMI is.
Exercise.
You said alcohol.
Oh, I'm sorry. Sorry. Definitely not alcohol. Exercise. The physical activity led to a reduction in breast cancer risk for premenopausal and postmenopausal women. And it also held true regardless of breast cancer subtype. So estrogen receptor positive or estrogen receptor negative breast cancer all had a reduction in risk with exercise. Current exercise recommendations are 150 to 300 minutes of moderate intensity physical activity per week, or 75 to 150 minutes of vigorous activity per week, or some sort of combination. When they talk about moderate intensity exercise, they recommend the talk test. This says that during moderate intensity activity, you should be able to talk but not sing during the activity. So walking briskly, doing water aerobics, kind of a slower bike ride, doubles tennis, those sorts of things. Vigorous intensity is you shouldn't really be able to say, more than a few words without pausing to take a breath. So if you're jogging, running, swimming laps, jumping rope, those sorts of things. Tobacco causes breast cancer, most cancers. It's estimated that about 5.1% of breast cancer related deaths are attributed to tobacco. Tobacco contains at least 20 known carcinogens. The good news is smoking rates have gone down, and we have seen a decrease in tobacco related deaths. It's declined from, hard for me to say, 6.9% to 5.1% over the last, say, 30 years. The next thing I'm going to talk about is hormone replacement therapy and breast cancer risk. And the reason I'm going to talk about this is because about 80% of breast cancers are caused or stimulated, I should say, by estrogen. And there's been about 20 million breast cancer cases diagnosed since 1990 in Western countries, and they've attributed about 1 million of those to hormone replacement therapy. You can see in this graph here that hormone replacement therapy really took off in the 1990s, but then it had a rapid decline in the early 2000s when the Million Women study came out that showed a link with hormone replacement therapy and breast cancer. Currently, there's about 12 million current users of hormone replacement therapy. This is a study by the Collaborative Group on Hormonal Risk Factors in Breast Cancer. It was actually a meta-analysis of 58 studies that included 570,000 patients. Let me see if I can show you. So this area here is estrogen only hormone replacement therapy, and this is estrogen plus progesterone. And what they found was the breast cancer risk is greater with the combination estrogen and progesterone. They also found that current users of hormone replacement therapy have a higher risk than past users. And up on the top here is current users, past users down on the bottom. And the longer you take it, the higher your risk. They then broke it down with current users to see, did the method of hormone replacement therapy impact risk? And they found that estrogen pills were just the same as transdermal estrogen or the patch. They did not find very much risk at all with topical transvaginal estrogen because there's little systemic absorption. It also won't really help with hot flashes and night sweats. And the different preparations of estrogen and progesterone really didn't matter. Similar effect. When they looked at past hormone replacement therapy users, when women stopped taking hormone replacement, the risk for breast cancer seemed to persist even beyond 10 years. The risk was greater with longer duration of use. But if you took it for less than 1 year, there was very little risk or almost no risk. So we generally recommend not taking it, but if you need to take it for really bad symptoms, to kind of have a plan to limit the use and don't just continue it indefinitely. So summary of kind of all the recommendations to reduce the risk of breast cancer: follow healthy eating patterns, vegetables, fruits, whole grains, limit your red or processed meats, limit soda, limit highly processed foods. It is best to not drink alcohol. If you do decide to drink, limit your consumption to no more than 1 drink per day. Be physically active, exercise regularly, limit sedentary behavior like sitting on the couch and doing screen time. Don't smoke, avoid hormone replacement therapy, and if you do decide to take it, limit your duration of use. Thank you. Were we going to take questions now or at the end?
At the end.
At the end, okay.
Hi, I'm Nakayama. So I tried to get creative with my PowerPoint, so it is moving a little bit, which I think is a win. The fact that it is in fact moving. So I called this treat your body like a temple. The truths and myths and risks of developing gynecologic cancer. I took a more broad view thing. I'm going to lose on the study standpoint to my colleague that just finished. So if you have questions about the data, I'm more than happy to go into it at some point. So what we're going to cover is ovarian cancer, endometrial, and cervical cancer, which are kind of the big three in GYN. So ovarian cancer, it's the deadliest gynecologic cancer, about 13,000 deaths a year. It's the second most common, about 20,000 cases per year. It is actually going down over time, which is good news. Probably because of screening, not screening, but like prophylactic surgeries and things like that. The lifetime risk, and the reason why I bring this up is it's in the neighborhood of up to 2%. If you have a genetic predisposition, something like a BRCA, it can be anywhere for like around 20% for a BRCA2 to about 45% for a BRCA1 mutation. So it's highly dependent on what your particular genetic risk factors are. So how can you protect yourself? Well, heritable, obviously, you can try to do some sort of genetic testing. Now, I'm going to throw this out there. I tell a lot of patients that cancer is kind of like ice cream. And it's all ice cream, but there's different flavors. So the most common flavor, the vanilla, in my analogy, is something called high-grade serous ovarian cancer. There's a lot of different other ones. There's low-grade serous, and then there's mucinous, there's others. So a lot of the things that we're talking about are kind of one of the most common kinds of ovarian cancers. So the risk factors can vary depending on the flavor of cancer that you have. So BRCA, BRIC1, RAD51, those kind of mutations are more associated with the high-grade serous, which is the most common type. In terms of environmental, there are lifestyle factors, exposures, and protective factors, and we'll just kind of go over some of those. So in terms of protective factors, having kids is protective. Taking birth control pills, that's in fact something that we tell a lot of BRCA1 and 2 carriers, because when you're young, you find this out, get your genetic testing done at 21. Well, what am I supposed to do about this? I want to have kids. And we don't recommend that you have a prophylactic removal of the tubes and ovaries until you're older. That depends on what your particular mutation is, but it has been shown that if you take birth control pills, it does decrease your risk of ovarian cancer. Tubal ligation, taking out your tubes and ovaries, also shown to decrease. Now, breastfeeding, also been found to decrease the risk of ovarian cancer. What increases your risk? I tried to find lifestyle factors. Obesity, questionable, unclear. There's no clear evidence, diet, exercise, smoking, or infertility increasing your risk. In terms of history, endometriosis, which is something that causes a lot of pain in women, is a risk factor for a particular variant of ovarian cancer. I, in fact, took one of these out 2 days ago. If you have endometriosis, it increases your risk of endometrioid type, which is a different kind of flavor of ovarian cancer, and clear cell cancer. PID is pelvic inflammatory disease. That's an STD kind of infection. And the last, obviously, is family history. I can't remember exactly how long ago it was, but talc. There was a lot of lawsuits about talc that kind of came out. There's no really great high-level evidence that shows that talc increases your risk of ovarian cancer. I did find some papers that said talc used to be contaminated with asbestos, and asbestos is associated with ovarian cancer. So maybe some of that talc was actually an asbestos associated. Other chemical things have been thrown out there, but talc and asbestos are the big ones that people seem to bring up when they come into the clinic. So that's kind of ovarian cancer. Moving on to endometrial cancer. I still have a typo in here. There should be a C after that N. So I tried my best, guys, but I still had a typo. So this is the most common GYN cancer. What's interesting is it is becoming more common. Interesting kind of in a bad way. So there's about 68,000 cases a year. Why is this increasing? I'm going to hit that in a second, okay? The lifetime risk is around 3, maybe a little bit higher percent. The heritable one in here is Lynch syndrome, which has a risk. There's data all over the place, so I put up to 70%. What I did this slide on heritable cancers. So Lynch syndrome, which is up to 5% of the cancers, that's what this slide of a woman. These are all the different things that can be associated with Lynch syndrome. What's interesting though is historically Lynch syndrome was associated with colorectal cancer, but what's been found is that the endometrial cancer shows up before the colon cancer. So now basically every endometrial cancer patient is screened for Lynch. And we see, oh, do you meet certain criteria? It's 4 different tests that we do. It's called an IHC. It's done on the tumor. And if you screen positive, then we send you on for confirmatory genetic testing. And what's great about that is if you find the Lynch syndrome early, maybe you can get them set up for extra colonoscopies and all the other things that you're supposed to do for Lynch syndrome to try to prevent the other cancers. So that's something that's just getting done everywhere. Cowden syndrome, that's not very common. The thing that's interesting about that is they tend to have very large heads. So if your hat doesn't, if it's a person that doesn't fit a normal hat size, that's what I look for when they show up into the clinic. They also tend to have these little growths on their skin and in their mouth. It's something to look for. But if someone has a larger size head, it's something to look for Cowden syndrome. I actually have a patient that has Cowden syndrome. BRCA. So BRCA1 is interesting. There was one trial that showed maybe there might be a increased risk of higher, like a higher grade type of uterine cancer with BRCA1. But the data for that is kind of not so great. So that's why I put a question mark after that. Again, we'll take a look at the environmental, lifestyle exposures and protective factors. So the biggest increased risk is excessive estrogen. And I remember how I told you why the risk of endometrial cancer is going up. It has to do with the rising rates of obesity in America. So what happens is when you go through menopause, you don't have a cycle every month. So what normally happens when you're premenopausal is your ovaries say grow with estrogen. Then you have your period, but that's secondary to getting a progesterone load after you ovulate, and it tells you to shed, and you repeat the cycle. Okay, once you go through menopause, you don't get those signals anymore. You never get that shed signal. So what happens is androgens, which are like male hormones, which are still produced after menopause, are converted in fat tissue to a weak form of estrogen. So the more fat tissue there is, the more estrogen, the more your uterus grows, and there's never a shed signal. So in theory, what happens is over time, you just keep seeing that grow signal, which is a way to get cancer. So obesity is a big risk factor for endometrial cancer. Like I just explained to you, you should shed and get rid of that excess tissue. So if you have irregular periods, or that is potentially a sign that you didn't ovulate, so you never got that shed signal. So that can put you at an increased risk of getting uterine cancer or a pre-uterine cancer called endometrial hyperplasia. There's one disease called PCOS, polycystic ovarian syndrome, which is kind of classic for that. Estrogen producing tumors. There is one ovarian cancer. It's a relatively rare one that just shoots out a ton of estrogen. So it's not uncommon to find a coexisting endometrial hyperplasia or endometrial cancer in someone who has a granulocyst cell tumor of the ovary. External sources, like my colleague who just mentioned, hormone replacement. Phytoestrogens, that's a little harder. There's all sorts of studies been shown on this, but there isn't really a conclusive answer. So, I always err on the side of caution and try to limit people from that after they've had if they have endometrial cancer or not. Tamoxifen, which is also relevant to the last topic, is that's often given to people who have breast cancer, and it increases the risk of uterine cancer. It's a drug it's not exactly the same as estrogen. It works as an agonist, which is a plus, and an antagonist, which is a minus in various places. It just happens to work as a plus in the uterus. So you can get that growth signal in the uterus. And it's also been associated with some of the rarer forms of uterine cancer. So something to be aware of. Weird thing is it also makes the lining of the uterus look wider. So like if you're doing an ultrasound to see how wide your uterus is, it can mess with that. So it's something to know, like when someone walks into your clinic, and you want to make sure that you keep that in mind when you're deciding to do a biopsy and something like that. Protective factors. This is the only time I've heard that smoking's good. You know, what happens is smoking decreases your estrogen, so it's protective for uterine cancer. I can't believe I'm saying this, but it's true. It is what it is. Birth control, because it regularizes your cycle. Diet and exercise, you decrease the risk of obesity. Increased parity and breastfeeding, these are all things that are protective. Last but not least is cervical cancer. This is a radical hysterectomy that we did a couple of months ago. You can kind of see on the top, I don't know, but for the people in the room, that's the uterus, that's an ovary, that's a tube, this is your cervix, and this is the stuff on the side called the perimetria. That's the hardest thing to get. So that, you know, you never want a radical hysterectomy if you can avoid one, so don't get cervical cancer. It's the third most common cancer. It's related to resource availability and vaccination rates and things like that. So what increases your risk? Low socioeconomic status, which probably has to do more with, do you have access to pap smears? Do you have access for follow-ups of those pap smears? Do you have health insurance? So you're even getting the pap smears in the first place. Smoking increases your risk of cervical cancer. Birth control, there's conflicting data on OCPs. When I was a resident, I was told that it increased the risk, but it seems less so now. And I was even able to find data that the IUDs actually decrease it. Maybe that decreases the risk of inflammation or something like that. So HPV. HPV is a virus that almost everybody gets once they become sexually active. It's just passed around and most people get rid of it, but there are some people that just can't. So a lot of the risk factors are due to like sexual function. So being sexually active earlier, that increases your risk of cervical cancer. Lots of partners, especially if they're high risk or if you have a lot of STDs. Those are all things that increase your risk of HPV-related disease. And immunosuppression, which kind of makes sense because HPV is a virus. So if you can't fight off the virus, then the HPV is going to run around, and then you're at high risk for cancer. So people with HIV, people who have transplants, I see a lot of rheumatoid arthritis people who are on like chronic steroids and immunosuppressants. Those are the kind of people that you worry about a little bit more. So the vaccine, the most current one is a 9-valent vaccine. And what it means by that is it goes against 9 different kinds of HPV. So there's high risk and low risk. The low risk ones cause genital warts, and the other ones, the high risk ones, cause cervical cancer. So when should you get it? Ideally 11 to 12, but it's allowed up to 45. The idea is to get it before you become sexually active so that you've seen all the HPV. You're already immunized against HPV before you're exposed to it. But if there is some protective effect, even if you get it later on. Efficacy, dysplasia is like pre-cervical cancer. So if you get in, the ideal sort of situation, it's very protective against dysplasia. The cancer rates are a little bit higher. I saw all sorts of numbers, but anywhere between 87 up to 87% reduction in risk. To keep this on the myths thing, I tried to find things that people say about pap smears or HPV vaccination that isn't true. So pap smears are enough. That is not true. You should get the vaccination and decrease it. Pap smears are just trying to find the problem actually after you already have it. There's no safety data. That's also not true. There's all sorts of long-term data on HPV vaccinations. It causes autoimmune disease. I never heard that one, but I found that on a random website. It does not cause autoimmune disease. It should say doesn't. It doesn't work if you're already sexually active. I've already kind of explained that one. And males don't need the vaccine. Males are carriers. If you vaccinate the males too, then the women are less likely to get it. I have 3 boys. They're all going to get vaccinated. That's the way it is. And with that, I think we're ending with questions at the end.
I do appreciate everyone coming in person, and this was a fun topic for me. It's something that we always get asked by our patients, especially once they've been diagnosed with cancer. What can I do to help? Everybody wants to do something to help their disease, and obviously there's a lot of different treatments: surgery, chemotherapy, radiation therapy, and others. But they're always wondering, what should my diet be? What should this be? And it's tough because of the main reason that we don't have the data that we need. And so I'm going to kind of go through things more philosophically than perhaps data driven. But it's really because we don't have data. And I'm a huge skeptic when it comes to anything until I see the right data. And so I think it's important to keep that in mind, and ultimately to make sure if you're going to take the advice of something that you've heard from a friend or over the internet or whatever, that it's not harmful in some way. And most things aren't, and so that's good. And so I never kind of tell a patient not to try something, because if we don't have data on it, it means that it might work. I can't tell you for sure. I just can't say, I can't recommend it because I don't know. I don't have data that suggests that it works. So just to get back to the basics here, and again, I'm talking more once you have cancer. So you've heard thus far kind of what increases your risk for cancer. And you might say it's all about the same, kind of what causes cancer to grow. But this is more of what happens once you have cancer. What can you do to change the course? So this is cancer development. You have the normal cell that then undergoes a genetic change and becomes a cancer cell. I guess my pointer doesn't work up there, does it? And once it becomes a cancer cell, then it continues to go. And basically, a cancer cell, or once it's transformed, it's growing on its own. So it doesn't matter what you do in your body or what your body does. The cancer just keeps growing, and it's no longer regulated the way a normal cell is. And that's why it's so hard for us to treat these cancers. They're very similar to your normal cells, except they just keep dividing and growing and dividing and growing. What we do know are all the mutations that exist. There are a number of hallmarks of cancer. In other words, you have to do all of these things in order for that cancer cell to become malignant, or that cell to become malignant. So you have to have this sustained proliferative signaling. You have to evade growth suppressors. You have to avoid the immune destruction, and so forth and so on. So we have all of those processes that a cell has to go through to transform into a cancer. And for each of those processes, we know the genetic mutation that occurs, that begins that process or allows that process to occur. And then, ideally what we need to do then is target the proteins that are developed, or the mutations that are occurring. And that's what most of our new drugs are doing. They're trying to target those different mutations. But as you can imagine, if your cells are now mutated, they don't respond like normal cells. And the things that we can try to do to change the growth of those cells are very limited. So this I show because when my daughter was in elementary school, she did a science fair project, which was basically, she looked at household items and how cancer cells responded to different household products. So basically, she grew cancer cells in a dish and she poured different household products on them just to show whether or not the cells were alive or dead. And basically, Clorox was the best, killed all the cells. And so no surprise. But and you all know this. But I think the point is that even though we can kill cells in a dish, that doesn't mean that it's a good cancer treatment, right? And so, that's where we often get trapped a little bit with somebody telling us, hey, this works, it kills cancer cells. And people publish these. She didn't publish this, unfortunately. But people publish different things that work in a cell, and myself included. But once you try it in animals, there's a million reasons why you can't translate therapies from what works in a dish to what works in an animal, let alone what works in a human. And then there's the problem of anecdotalism. And this is the other problem that we get into, because we all have heard of someone that had a good response, and you want to grab onto that good response, and you want to know why it happened, and I do too, and why did they act differently than somebody else. But you have to be careful, because the problems with anecdotes is we never really have enough data with that anecdote to really know what caused the effect. And I apologize for this analogy, but for whatever reason it rings with me, which is, this is an instrument that the ancient Mayans used to scrape the inside of a child's urethra to get blood out of the child's urethra, in order to use that as a sacrifice to the rain gods. And you have to, you certainly imagine how insane that is. But you're talking about what was considered a very advanced society, smart people. How did they get there? And they got there through anecdotalism. They needed it to rain, right? And and their knowledge was that the rain was controlled by this person, Chak, who was the Mayan god for rain. So the way that you could get it to rain is to sacrifice to this god. And so what happens? You start out with giving them some presents, right? So you give the god some fruit, and the reality is that worked, right? It rained. So it wasn't raining for a while. They laid out their fruit and it rained. So they realized that worked, and maybe that worked for a few years, but then it didn't work anymore. And so that it just escalated. It escalated to then sacrificing animals because it wasn't enough and it worked, right? It rained again. So every time they escalate, it worked. And you evolved into this crazy thing where they were taking out, beating hearts in order to get it to rain. And eventually they were, doing other crazy things. So, it's not that it didn't work, it worked, but clearly it wasn't working in the way they thought it was working, right? And in reality, it was just that nature was bringing the rain. But from their perspective, they saw that what they did had an impact. And so they kept doing it. And when it stopped working, they tried something a little more. They never went back. They just kept moving forward. And that's what we have done in medicine in a lot of ways. And we think about the radical mastectomy as one of those ways, where we started out taking out cancers, and in some cases it worked, and in some cases it didn't. It came back. And the philosophy was, well, it came back because we didn't take out enough. And so we just kept taking out more and more and more, and created these kind of radical operations with the thought that all cancer within the body was connected in some way. The more tissue we took out around the cancer, the better we were. And Bernie Fisher, who practiced all his career in Pittsburgh, was really the founder, not the founder, but really promoted the randomized clinical trial as the way to really define what works and what doesn't in cancer care. And so And so, he really transformed the way we thought about hypotheses and how to test hypotheses in the clinic. And so he began randomized clinical trials and found, lo and behold, we don't actually do better when we take out all this crazy tissue around cancer, and we can get it. All we really need is a lumpectomy and some additional therapy to try to treat any cells that have escaped from the primary tumor. So really transform care, but also that point of, anecdotes aren't really the way we should practice medicine. We need to practice medicine using randomized clinical trials. It's tough. So doing randomized trials are expensive, and it's very difficult to run these trials. These can be massive trials, often need to be. And so the reality is, for a lot of what you wonder about, like, does it help to have vitamin C, or does it help to have vitamin D, or does sugar, increase the growth of cancer? Should I stop eating sugar? All of these things, many of these things have not been well studied, because to do a large scale randomized trial is just too expensive. Who's going to do it? Nobody benefits at the end of the day financially. So how do we get these things done? The government did, the NIH did support a lot of research around these different agents, and they developed a branch of the NIH that would focus on these reagents. So through federal funding, we began to see some randomized trials come forward with different agents that had been tossed around for a long period of time. And I just show a couple of examples because there are a lot, but this was one with vitamin C, because vitamin C had been talked about. Everybody was convinced it could help. Everybody was getting intravenous infusions of vitamin C. They were taking a lot of vitamin C. And then this is just an example of one randomized trial, but there were a number of randomized trials where you can see survival, the red being the patients that got vitamin C, and the blue, those had a placebo. They had a pill that they thought was vitamin C, but it wasn't. And there's absolutely no difference in overall survival. And so I think, we have a few myths busted, like vitamin C. That doesn't mean people aren't continuing to use vitamin C, and there are still clinics that will deliver IV infusions of vitamin C. The reality is it's probably not harmful. And so, I'd never tell somebody, but I try to at least let them know that the data so far says that it isn't effective. This is vitamin D. So after vitamin C, vitamin D became very popular. A lot of randomized trials in vitamin D, and this is one of those meta-analysis where you combine all the studies together. If it's on the right of that line, number one, then it shows that the placebo worked better than vitamin D. If it's on the left of that line, the vitamin D worked better than the placebo. And as you can see, it kind of ends up right in the middle on average. So vitamin D did not really help, although some studies did show that it looked like it had an advantage. Others show that the placebo had an advantage. So even randomized trials aren't perfect, and sometimes you have to repeat those many times. And this is a randomized trial of dietary intervention. So a lot of what Dr. Coopey talked about, are correlations with diets and how those diets may impact cancer risk. But it's very hard to prove that a diet manipulation causes cancer. So even though drinking sugar may be associated with an increased risk of cancer, that doesn't mean sugar causes cancer. It just means that, for whatever reason, there's an association, but may not be a causative effect. And it goes back to just the fact that they can sacrifice a human being and it would rain. It's associated with rain, but it doesn't mean that the sacrifice caused the rain. So that's what we just have to keep in mind about these studies. And this was a randomized trial. Fats, there were so many retrospective studies looking at fats and the risk of dietary fats causing breast cancer. This is an older study, but so they randomized patients ahead of time to decrease their dietary fat consumption. They were able to do that by 10%. And then they followed those patients, and they did not see a difference in overall survival. You can see that the the intervention at a higher, I'm sorry, not survival, but they were looking at incidence of breast cancer in patients. Those that they intervened on actually had a little bit of a higher risk of, or a higher incidence of breast cancer than those that they, than the control group that they didn't intervene. So anyway, once it was tested in a randomized trial, it didn't really stand up. So does sugar feed cancer? You know, the thinking is that cancer cells that are growing, they're dividing, they eat a lot of sugar, right? Sugar is the main source of metabolic fuel for the cell. And since these cells are very active, they're eating a lot of sugar. But so does your brain cells, so do your, you know, all your cells eat sugar. And so, yes, it eats more sugar, perhaps because they're growing faster and they have a higher metabolism than your normal cells. But that doesn't mean that you can somehow impact the growth of those cells by starving yourself, because the only way to decrease all the sugar, you know, in your body is to not, you know, is to basically die, overwhelm yourself with insulin, and then your brain also lacking sugar will lead you into a coma. So you know, the reality is we don't think you can manipulate cancer growth with sugar intake. Now, has that been tested well enough for me to say that's definite? No. So, you know, I never, you know, there are a lot of people that are promoting keto diets in different ways, and you know, we just don't know at this point whether those are going to have a major impact in cancer growth. But I think there's some flaw in the original concept of this. I go back, I did a lot of metabolic work when I was actually a surgical resident, so this was a long time ago, where I actually, in animals with tumors, manipulated the glucose levels, the protein levels, insulin, somatostatin, a variety of things, so I could completely control the metabolism. And I've always thought about that because I could completely eliminate protein out of the animal's diet, and the tumor would barely grow. So tumors need protein just like they need glucose. If you eliminate protein from the diet, the tumors don't grow as fast. But unfortunately, as you might imagine, neither does the host. And so what you found was that the host became very cachectic, the animal, and the tumor barely grew. And there was no overall benefit for that in that situation. And so it just told us that, you know, we had to, you know, while we can manipulate things, it's very hard to differentiate and, you know, have the cancer grow less while we still build up the body. And so, you know, we do know, as we've talked about, that obesity can impact cancer growth. And so, you know, we do feel like the good balanced diet, as you've heard, is the best thing to consider when you're when you have cancer. And so you know, it's kind of the common sense thing with vegetables, starches, proteins, good fats. And there are a variety of reasons that we know that obesity can correlate with cancer growth. So we think that diet may have an impact on that. Exercise, we talked about, while a lot of, you know, there's a lot of data around the association of exercise and decreased cancer risk. There's also the consideration that exercise can improve cancer-related outcomes in patients that already have cancer. And we have the exercise oncology program as part of, at Suburban Hospital, as part of our Cancer Institute. And Dr. Champ has done a lot of research to show that, you know, good resistance training, to the point where he writes a prescription for how much resistance training can improve overall outcomes of cancer, but we don't know why that happens. So he's doing the research, and he's doing a neoadjuvant trial now combining chemotherapy and a specific exercise program before patients get their pancreas cancers taken out, to try to get more information as to how the exercise may be impacting the overall outcome. And then can you control a cancer by thinking about it? And we know that's not true. We can't think about cancer and it will grow slower. But there are a lot of things that is extraordinarily important about maintaining good mental health while you have cancer. And it will prolong survival in that if you have good mental health, you're going to tolerate the treatments better. You're going to be able to stay active, which we think is helpful, and a variety of things that will improve the overall outcome of the cancers of the cancer. So, we do think mental health is extremely important, and this is I think an important factor which looks at the performance status and how performance status is associated with survival in patients with cancer. And performance status is just how active you are, how well you are overall, how much time you're up and around versus in a chair in bed. And regardless of the cancer, so this is all comers with cancer, if you're in good condition, overall, you do much better. If you're kind of debilitated to begin with, it's not as good of an outcome. So I think what that tells me is that we need to do all the normal things to stay healthy, but once you have cancer, it becomes even more important. So it is the good diet, the exercise, staying mentally healthy, putting all that together to get the best overall outcome for cancer. And again, so stay in the best general physical condition with a well-balanced diet and exercise, stay in the best mental condition. And from my perspective, it's fine to try new things that you've heard about, but I think keeping, in the caveat that or understanding that, it may not have been proven in the appropriate way and may be an anecdote that we need to consider and make sure it's not doing any harm. But if it's something that you have faith in, then I think it's reasonable to try. And then most importantly, I think, is consider the clinical trials, because that's where we're really going to learn more information about what works and what doesn't work. That's where we can really advance the field overall. So I will stop there, but thank you. And maybe we can all come up and answer any questions that you have.
Okay, we do have an online question, and it states, can you comment on the use of ivermectin in breast or colon cancer?
So ivermectin, is one of those agents that works on cancer cells. And so if you look at cancer cells in a dish and you treat with ivermectin, those cells will not, divide as rapidly. So it does have an impact, but really has not been studied in preclinical models and is not in clinical trials right now that I know of. So it has not gone through any of the kind of more clinical rigor to say whether it's impactful. So, it's like a lot of things. I think it needs more research to say whether or not that's going to be an effective agent to combine with different drugs, but there are good in vitro studies basically showing that it has an impact and can combine with chemotherapy agents to improve cell death in a dish.
I see an additional question came in. 1 moment. The next question is, if we're recently diagnosed with cancer and being treated at AGH, how do you get connected to the oncology exercise program? Do you ask your oncologist for a prescription questions?
So there's a couple of ways you can do it. The Hope line for cancer, you can connect through that. Do we know the number there?
We will be bringing it up there.
Okay. So the Hope line is one way to get connected. The other is to ask your physician to make a referral, and then the physician can contact the exercise oncology program and get you connected.
Okay, thank you. The next question is, If hormone replacement therapy increases recurrence for ER positive, why would that be prescribed? Questioning that.
So hormone replacement therapy is different than what we call hormone therapy or endocrine therapy. What we give to treat the breast cancer is actually anti-estrogen. So I know that that's a little bit confusing. We actually give anti-estrogens to treat the breast cancer, even though it's a form of like hormonal manipulation. Good question.
But there may be a question there as to why replacement therapy is ever recommended.
That is a whole ball of wax. There's all sorts of guidelines about that. There's something called the Women's Health Initiative that came out. It looked at a large number of women, and the study was actually started to try to show that hormone replacement decreased the risk of cardiovascular disease, and they found the opposite. So that's why you saw that peak in her chart. That's what happened. The Women's Health Initiative. Now, if you do estrogen alone or the combined estrogen and progesterone, it had like different risks for you. But I believe the party line is still, if you're going to do it the shortest amount of time with the least amount possible. And once you start talking about cancer, if your cancer is hormonally responsive, like breast or endometrial, you got, all bets are off, right?
We have one final question, and in the interest of time, I think we'll close it to questions to stay on time and be respectful of everyone's time. This final question has to do with food, and they're inquiring about whole foods versus organic hormones. Is organic food healthier and less cancer causing? Is the general question.
I think we do believe that kind of processed sugars and are more likely to be a problem. And so in general, we do recommend organic. I think the other issue is just whether or not there are some, additional hormones that are given to the animals that might have an impact. So while, again, one of those things that's not proven, it kind of falls in line with what we say is a healthy diet to avoid the processed sugar, processed foods.
Okay.
We'll move ahead with closing it out. Just hold on. All right, if there are no other questions, we would like to thank all of you for attending our Ahead of Cancer lecture this evening. Please continue to join us at our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorships. As a reminder, tonight's lecture was recorded. If you are interested in rewatching tonight's lecture, check back on the AHN YouTube channel, www.youtube.com/Allegheny Health Network for the full recording in about a week. This video, as well as all other past lectures, will be available under the Ahead of Cancer playlist. If you would like to schedule an appointment or have questions regarding a potential cancer concern, please call the Hope line at 412-578-4673 to schedule an appointment. Again, that was 412-578-4673. You may also call our 24-hour Nurse for You line at 412-687-4968. Thank you for the wonderful presentations, and thanks to all who attended the lecture this evening. Have a wonderful evening, everyone.